Hi, this is Heidi Nelson, CEO at Duffy Health Center. Welcome to this episode of Duffy Doings, our show about issues related to healthcare and homelessness on Cape Cod and what's going on at Duffy Health Center. Today my guest is Louise Patrick, Director of Behavioral Health Services at Duffy Health Center. Welcome, Louise.
Thank you, Heidi.
We're glad to have you on the show.
Good to be here.
So we're going to talk about behavioral health, and I'll ask you in a minute or two what behavioral health actually means, but a couple of episodes ago I met with Dr. Lisa Zandanella from Duffy and talked about the medical aspects of addiction. And you know, it's in the news almost every day about the problem of opiate addiction in particular on Cape Cod and in Massachusetts. We have high rates of overdoses in Massachusetts and on the Cape, and recent data shows that frighteningly on the Cape we have some of the highest rates in the state of overdose deaths. And I heard an interview recently from the chief of police in Gloucester. You know, he's famous for providing, anybody who walks into the police station, they'll get them into treatment right away. But he said that he thought that the primary reason for all of this heroin and opiate addiction is because of the availability of heroin and how easy it is for people to get it, opiates and heroin. But I think what really concerns people and what really scares people is just how quickly, you know, somebody can fall into that kind of addiction. So that'll be something that we'll talk about as we move along with the show. But really what we want to really emphasize here is what we do at Duffy and how we help people to make change in their lives and to end their cycle of addiction. So behavioral health. Tell us what behavioral health means.
Well, it's interesting because a lot of people are still confused about it. It's really a broad term used for a wide variety of services, including mental health, substance use services, and that includes individual treatment, group treatment. It also includes psychopharmacology, including medication evaluation and medication management. So it's really a broad term.
Right, so the medications that psychiatrists prescribe to people
psychotropic
who
meds,
have mental illnesses. So, so what kind of qualifications do you have to provide behavioral health services?
Well, you have to be a licensed provider, starting with a bachelor's degree and then enter into a master's degree program, like social work, for instance, or counseling psychology. Those programs involve the attendant internships, 1 or 2 year internships, so many hours of clinical supervision, and then usually 1 or 2 licensing exams.
Okay. So then you can provide therapy. You can provide
Right.
therapy and treatment to patients. So, so you know, in the old days, there was always the joke about being on the couch, you know, with your psychoanalyst and talking on and on about your problems. But now I know that we really have standards and there are protocols about what therapy is all about. So what are the goals of therapy or mental health treatment?
Well, generally people come into treatment when they want to change something in their life, that they're unhappy or uncomfortable with something that's going on in their life. So the goals can be whatever they want them to be. The important thing is that our clients or patients make their own goals. The providers do not make goals for the patient. So there's a lot of self-determination involved. So it's really the job of the therapist, through interviewing, motivational interviewing, which I know we'll probably get a chance to talk about a little bit, to uncover what changes a person wants to make and and decide what the steps are on the way to achieving that goal. And some of these goals, I talk to patients all the time about, some of the goals that we're establishing here will be lifetime goals. For example, recovery is not something that gets achieved and then it's over. That's a lifetime goal, whereas something like losing weight or stopping smoking or something like that.
Well, you can help with that?
I can try.
Oh,
good. That would be a more, not a short-term goal, but it would be a goal with an end.
Understood.
Yeah.
Understood.
Yeah.
Okay. Well, let's get back to medication-assisted treatment for a few minutes. So, when Dr. Lisa was here, we talked about Suboxone, which kind of helps to take the place of the effects of opiates and heroin on the brain receptors, and then Vivitrol, which is another drug that kind of blocks the effect. And so medication-assisted treatment is something that the federal government and the state is also really trying to incentivize primary care providers to provide more medication-assisted treatment. You know, when we think of treatment, we think of detox beds and rehab facilities, but really medication-assisted treatment is a way in outpatient services that people can kind of bypass all of those costly services and receive their treatment services outside of the four walls kind of a hospital. But tell me about how behavioral health, so there's a medication, but how does behavioral health fit into the whole treatment process then with medication-assisted treatment?
Well, it's something that I usually try to provide a lot of education around because the medication helps with, blocking the cravings and so forth, and it helps with the physical part of addictive disease. But addictive disease really has a lot more symptoms than just physical symptoms. There are psychological symptoms, there are emotional symptoms, behavioral symptoms, and spiritual symptoms. So, what behavioral health does is help people address the symptoms of addictive disease through therapy. And just to give you an example, one of the psychological symptoms with addictive disease would be black and white thinking, or all or nothing thinking, or thinking I'm not responsible for anything. And in recovery through therapy, we can help people get to a point where their thinking is a little bit more flexible, it's not so rigid, that they can put a label on their emotions and talk about it instead of stuffing it, as people often do in the throes of addiction, is not talk about their feelings. It's really a big part of recovery. The medication is good, and fortunately, we have a wonderful team who understands that very well, that it's not just the medication. There's this whole other piece people have to work on to really change their whole lifestyle, change the way they think, change not so much how they feel, but how they manage their feelings, change their behaviors. It's quite a process.
Well, and some of the treatment techniques that you use are to help people identify their feelings. And when I start to feel like this, that's a danger sign.
It's a trigger.
And how you can sort of change your reactions.
Absolutely, absolutely. We utilize cognitive behavioral therapy, and most of us are trained in that. And basically, cognitive behavioral therapy helps people recognize how they think, what they think, and how their thinking affects their emotions, and how their emotions affect their behavior.
We all can understand
That's
that.
right. That's
for
right.
sure.
So the first step is starting with what is it you're thinking, and is there another way to think about that? Is there another perspective that will help you? Another symptom, I would say, of, and this gets to cognitive behavioral therapy too, that we often see with addictive disease is that the cup is half empty. And meaning that I'm focused on everything that's wrong in my life. And you know, I have no gratitude or no appreciation for what's going well. It's just all about what I don't have. And I think with something like cognitive behavioral therapy, we can help people sort of recognize what they have to be grateful for and how they can turn that sort of negative, maybe self-pity into a sense of gratitude and appreciation, and which results in a positive, much more positive attitude for people. Yeah.
And if people practice thinking that way, it may actually change the way they feel.
And you know, I think that's what we try to help people to do.
Sure,
Yeah.
sure.
Yeah.
So you've been talking a lot about change, and I know there's a concept called the stages of change, and that's really important. And interestingly, we think a lot about people with addiction need to change. You know, they need to make change in their lives, but we all need to make change. You were talking before about losing weight or quitting smoking. So stages of change is kind of a way to think about any kind of change that somebody wants to make. You want to talk about what the stages of change are?
The stages of change are, I think, pretty simple but profound. It starts with pre-contemplation. And pre-contemplation, I think of that as whatever it is people think I have a problem with is not even on my radar screen. And that's often true with addictive diseases. It takes a long time for people to accept that I need to make a change. But other people may be telling them, the you know, legal people might be telling them, or family members, or employers and so forth. So pre-contemplation is, I'm not even thinking about it. Contemplation is usually when there is a little bit of movement or a crack in denial, perhaps, that, yeah, maybe I need to make a change. And it's kind of a stage where people are on the fence and sort of go back and forth. Maybe I need to make a change, maybe not.
So they're still thinking about it.
They're thinking about it. And they could stay in that stage of change for years. And that would be people, say, who were relapsing frequently, that they're just not quite ready. The next stage is determination. And that's when the person has really moved into, I guess you would say, acceptance, and I need to do something. What that is, there are a variety of things. And then after a person reaches determination, they take action. After the action step, there's maintenance. And at any point, the stages of change are often depicted in a circle. Relapse can happen in any stage. And the thing that's really interesting, I think, about stages of change, and we have to keep this in mind all the time as providers, is that somebody might be in the maintenance stage of change from opiate dependence, but be in a pre-contemplation state of change for smoking marijuana.
Oh, okay.
So you're working with people in different stages with different behaviors or addictions or problems.
Right.
So that can be a little tricky too. And as long as we can help people clarify that and discover that, we can work with it. Yeah.
And I think that would be, I can see how that would be really helpful if you had a tool to talk about what stage do you think you're in?
Yeah, absolutely.
Related to this or that problem.
And people are usually pretty accurate about it.
Yeah, isn't that funny?
Yeah.
That's interesting.
Yeah.
Well, and so I've heard the term motivational interviewing used as a tool to kind of move people through the stages. Do you want to talk about what motivational interviewing is?
That's also a really, some of these strategies or theories seem pretty, not real complex, but very profound in my mind. With motivational interviewing, the core of it, I think, is to help people discover what is important to them. what are their core values? And so, and that's a good conversation to have. What is it that you learned in your growing up years that was important? Was it important to be a hard worker? Was it important to be a trustworthy person? Was it important to be a good family member, responsible, dependable, all those things? So we try to discover what are the values that are important to each individual, and create a little discrepancy in interviewing them. When somebody says, I want to be viewed as someone who's trustworthy or someone who deserves respect, but all of their behaviors are contraindicating that because they're being dishonest or undependable or untrustworthy, then we can have a conversation about, these are the things that are important to you. These are your values. What gets in the way of living up to your values, and how can I help you get there? And I think oftentimes that when people hear themselves say something out loud, sort of with a witness present about, right, yeah, I guess I'm not, well, that's true. I really, I can see why people don't trust me. I don't trust myself. It's like an epiphany often, and it's so much better when they realize it themselves than if I'm telling them that.
Right.
Yeah.
Right. Well, one of the things that whenever I try to explain motivational interviewing to somebody when I'm giving a tour of Duffy or talking about what we do, I always say that, it's really better, it's going to be more effective to start with the patient's goals, not our goals.
Absolutely.
Our goals might be, we want you to quit using drugs,
yep,
and we want you to get an apartment and
yep,
be successful with your apartment. And the client's goals may be, I want to reunify with my family. That it's the same, probably the same endpoint, but just
exactly,
how you think about,
exactly,
how you're going to get there. And another piece of the whole process is understanding that you move forward, but then you move backward.
Absolutely.
You're kind of always going forward and backward.
Yep.
And that there are going to be barriers, and yep, identifying those barriers up front and what we're going to do when we face those barriers,
yep,
those kinds of
yep,
things.
I think that's true. As a matter of fact, I think it was during the cognitive behavioral certification course I was doing that one of the presenters was talking about 12-step programs being harm reduction and being a cognitive behavioral approach to recovery, because it's progress. One of the tenets of the program is progress, not perfection. So, and that gets to 1 step forward, 2 steps back. Sometimes graphics work really well with people. I used to have a graphic of somebody climbing a mountain and, climb up a couple of steps, hit some gravel and slide back a little bit, but it's a slip, not a fall, and so that way I think people can be a little easier on themselves and not expect perfection, because it is a process. Yeah.
Well, and it's so interesting too that motivational interviewing has been around in the substance abuse field for quite a while, but now primary care is really taking on, in the whole realm of chronic disease management, it's all about change, right? And so now we're training primary care clinicians and medical assistants and front desk staff, everybody we're training in motivational interviewing, because it's all about change, yep, right, of yep, any kind.
Yep.
So how does behavioral health, we always like to talk about our three-legged stool, yep, at Duffy, and how does behavioral health work with the medical department and case management to move people along and out of their homelessness?
Well, we have several ways of doing that. Of course, the most important thing is communication, that our patients have a team of providers, and the team is connected, and we start out every day with a morning huddle. We have regular multidisciplinary team meetings, individual care plan meetings. So we bring the different disciplines together. And it's always interesting because the disciplines are all trained differently, but we're all there to help the patient take the next step forward, even if it's just a tiny baby step. And oftentimes it is, and oftentimes that's the best way to do it. We also have we communicate through our electronic health record. With our medication-assisted treatment program, something as simple as being able to look at the appointment scheduler and see, for the medical provider to see if the patient is keeping their behavioral health visits. And
so you work together on that.
Yes.
So the medical provider can say, well, you haven't been going to see
and they
Louise,
do.
and so they
And they
encourage
do.
the patient to go see you,
right?
right?
And that happens, you know, more than I wish, but it's very effective. And I think you heard me say one time that there are a lot of eyes watching patients and trying to monitor what they're doing. And you know, it's the very thing that so many patients have said to me over the years: this is a really strict program, but I need
in a good
this.
way.
I need this. I want this. I don't want to go anywhere else where they don't require behavioral health, and you know, then it isn't as strict.
Interesting.
Yeah.
Well, we have a great team. We have a great team at Duffy, and we've been doing a lot of talk recently about what are the core competencies, we call them, but what are the traits of Duffy employees that make us Duffy employees? And we're sort of distilling that to, you know, I think we would say that everybody is smart and resourceful and passionate about the mission, and that we all believe in professionalism and operating within our professional ethics, and providing a lot of training to our staff so they can be at the top of their profession. What is it about your staff in the behavioral health department that you think makes them really special?
Well, I think it's all of the things you just said. It's a staff that's really committed to the patient population, so mission-driven. You know, you have to have a balance between having empathy for people, but also being able to help them motivate themselves. My staff is very interested in getting ongoing training and learning new techniques and strategies. Fortunately, we have a psychiatrist and a psychiatric nurse practitioner who work beautifully with our population, and it's a very special staff. I'm very grateful to them, and they work really hard, and there's a lot of dedication.
Right.
Yeah.
They're just pretty much willing to do anything, to do whatever it takes to get the job done.
Yep. Yep.
So very good, very good. Let's talk for a minute about our partnerships in the community. So one of the sources of referrals for our services is law enforcement. So you want to talk about how we work with the probation department and how we work with the correctional facility.
Yep, yep. We have a really tight relationship with both, I would say. I would hope I could say that the probation department relies on us to do substance abuse evaluations, and so we get a number of court referrals, and they rely on our recommendations, whatever the recommendation is based on the evaluation. The probation department is very conscientious about staying on top of what their folks are doing. And you know, talking about goals for treatment, Heidi, a goal for somebody on probation may be something as simple as I want to get this over with. And even though that might not be my wish for what their goal is, I'll work with them on that. Okay, so what needs to happen to make that happen? And we also have a person, one of my staff goes into the jail a couple of times a month, not as an inmate, but meeting with pre-release inmates, and tries to connect them to Duffy services if they are appropriate, if they meet our mission. And I was saying at a recent forum on homelessness, I had to give a shout out to the sheriff, because that's a best practice that Barnstable County House of Correction prescribes Vivitrol in the jail before people are released, and then they can come right to us.
That's
it's a beautiful thing.
That's right.
So, so we work closely together, and they're very good about probation. For example, they don't try to interfere with the therapeutic relationship in terms of saying, what are you talking about? What are you working on? All we really do with probation officers is give them the dates, the appointment compliance information, what appointments people had and which ones they kept, and then they can sort of draw their own conclusions based on attendance. So. Yeah, so that preserves the relationship, and because we want people on probation to feel that they can develop a trusting relationship with us.
Right. Very good. So let's talk about you for a minute. What brought you to your profession? Why did you decide to be a therapist?
Well, you know, I think I'm an old Kennedy era, you know, sort of mission-driven person. I was a Peace Corps volunteer, and talking about core values, one of the values in my family was to be of service. And so, and the phrase comes to mind, to whom much has been given, much is expected. So even though it's not as though I lived this privileged life, but there was always this expectation that if you have more than someone else, then you have a responsibility to reach out and help other people. So I knew I'd end up in a helping profession. I wasn't sure if I'd go into nursing or social work, but in the end, I went with social work, and I'm glad I did.
Yeah. And what about working with the population that we serve?
Well, you know, it's interesting, Heidi. I've been a social worker for 30 years, and I never saw myself working with the homeless. But what happened was, I was in my previous job, I had been there for 10 years, and I got a call from someone who had me in mind for this position at Duffy. This is, it'll be 9 years, I think, this year, and 8 or 9 years. And I wasn't sure, but when I came for the interview and I talked with the previous executive director, I said, I've got to be here. This is a happening place. This is cutting edge. This is good work, and I want to be a part of it.
Oh, very good. Very good. Well, we lucked out that you said yes. So let's go back to clinical talk. What is the concept of harm reduction? What does that mean?
Well, you know, when I mentioned progress, not perfection before, which is one of the tenets of AA, I think harm reduction, it used to be called risk reduction, and it's working with people, it's really a concept around working with people who may not be ready to commit fully to sobriety or whatever we would hope their end goal would be, that there may be just a baby step towards that goal.
Compliance with their meds, you know, all kinds of different issues.
Absolutely. Yeah. And so we we work with them around whatever they're willing to do. And if it's simply keeping them safe in so many ways, you know, helping them keep themselves safe, then that's what we're going to do.
Yeah, yeah.
It has to do with stages of change, because if somebody is really in harm's way and not ready, not in a determination stage of change, we will find a way to work with them if they are at risk.
And I think that's kind of what distinguishes what we do and what other harm reduction providers do is any positive change, right? That we want people to move in a direction. And I think that's why our clients keep coming back.
Oh, yeah.
Because they know that we're their cheerleaders and we're going to be there for them and we're going to be a support.
And
you know,
even if they're not ready at the first time they come in, they may be ready 6 months down the road, maybe
That's
2
right.
years down the road.
That's
and
right.
that happens all the time.
That's right.
Yeah.
Well, Louise, I want to thank you so much for being with us today. We've had a great conversation, I think, about behavioral health in general and medication-assisted treatment and what we do at Duffy Health Center and our fantastic staff. And you're an amazing leader, and we're fortunate to have you. And with that, we will sign off and look forward to seeing you on our next edition of Duffy Doings. Thanks for watching.